communities have been impacted and marginalized, and how we as an organization will work with our partners to address these issues and strive for change. And our focus today is on healthcare. So please let me first introduce you to my fantastic co-moderator, and then to our accomplished panelists. My teen co-moderator this afternoon is Adrienne Feliz, a teen leader with the West Side Y. She was born in Harlem and is currently a senior at the Urban Assembly School for Media Studies. She's been actively engaged with the Y for 4 years and has been a great leader among her peers, participating in a number of programs, including Teen Center, Leaders Club, and Rose Scholars. So thank you for being here. And now to our panelists. First, we have Ebony Carrington, who is currently the Chief Executive Officer of New York City Health and Hospitals Harlem, a public hospital that serves the communities of Central and West Harlem, Northern Manhattan, and the South Bronx. The hospital has 13,000 discharges, 206,000 outpatient visits, and 80,000 emergency department visits per year. In her role, she provides leadership to the hospital's inpatient, outpatient, emergency, and critical care units, and has fiscal and operational responsibility for a workforce of 3,200 people and an operating budget of over $400 million. So welcome, and thank you so much for being here. Dr. Julia Iyashara was recently appointed Executive Director of New York Presbyterian Hospital's Dalio Center for Health Justice. And in this role, she leads the center's efforts to address longstanding health inequities due to race, socioeconomic differences, limited access to care, and other complex factors that impact the well-being of our communities. The center will serve as a convener, collaborator, and grantor, bringing together renowned experts in diverse fields to fuel change and to support health justice among New York Presbyterian team members, patients, communities, and ultimately local and national policy. She also serves as the director of LEAD Academy of Physician Leadership and Career Development Program at New York Presbyterian Hospital. Thank you so much for being here. And finally, Errol Pierre, who is the Senior Vice President of State Programs at Health First, the largest nonprofit health plan in New York State, serving 1.6 million members. In this role, he is accountable for growth, profit and loss, sales and retention for the Medicaid and long-term product portfolios. Additionally, he provides strategic and operational direction for the company's newly launched Health Equity Foundation and Community Affairs. Before he was at Health First, he spent 12 years at Empire Blue Cross Blue Shield, the largest for-profit health plan in New York State. And I should also say he has been a great Y board member. So thank you so much for being here. So I want to start by saying I just shared some highlights from your extraordinary careers, but I would love to start with a personal, help everybody who's on the call understand you a little better. So may I ask each of you to spend a minute or two on what motivates you? What is your North Star within healthcare? And so maybe, Errol, if I could start with you, just for a moment or two, just to give folks a sense of what drives you for what you're doing. Sure.
Thank you. Thank you for the awesome introduction, and I'm honored to be here with such an esteemed panel. Thanks for doing this for the conversation. My North Star is really thinking about our most vulnerable populations. So my parents grew up in Haiti. My dad grew up in a little town called Gonaïves on a farm. And when he came here and I was born, it was very hard to navigate healthcare. It's confusing for PhDs. So imagine someone where English is not the first language. And so I think about that every day. My North Star is really making sure that whether someone is on Park Avenue in Manhattan or the Park Avenue in the Bronx, that they have equal access to high quality care that's respectful and honorable of their cultural differences.
Thank you so much. And Dr. Iyashara?
Well, not to steal what Errol has just said, although I think it would be very hard not to, because I think that's a lot of the reasons that I, come to work every morning and do the job that I do is that every day I think about how we can make healthcare better and how we can make sure that we are caring for our most vulnerable populations, how we can be innovative when we think about access to care, when we think about, measuring our outcomes and holding ourselves accountable for, the healthcare that we provide, and ensuring that everyone, regardless of a whole host of race, creed, sexual orientation, gender identity, etc., regardless of any sort of descriptor of you, that you have equal access to high quality gold standard care. And that's something that makes me happy to be able to do every day. So it was a little bit of it's always hard to follow when you are incredibly impressed by what someone has just said, because it really touches my heart in the same way. So,
thank you so much. And finally, Ms. Carrington.
I think that the prior two panelists have said everything that needs to be said when you have the right heart for healthcare. What I would offer and add is simply that I see my role as bringing social justice to healthcare. And so really trying to offset more than just the health inequities that bring people across my doorstep, including, access to fresh produce, making sure that they don't have to make difficult decisions in life around paying for co-pays versus paying their rent. And we'll probably touch on most of these topics later. I got into healthcare because of the disparities that we're going to talk about, and trying to offset them in a very meaningful and actionable way is my contribution daily.
That's great. Well, thank you all, and thank you all again for being here and for being such passionate advocates. And so now I would like to ask Adrianelli, who has some great questions to get us started, to begin.
Hello, everybody. My name is Adrianelli. I'm very excited to be here. And my first question is to the panelists, Dr. Iashira and Ms. Carrington. What were some of the challenges that both of you were expecting with providing care to the Black and Brown communities pre-COVID, and how have those challenges changed during the pandemic?
I'll start, and then I think this is a really clinical question, but what I will just offer is very similar to what we spoke about earlier. We see in Central and Northern Harlem healthcare disparities that are very pronounced in meaningful ways, where the mortality rates or the number of people who die from conditions that are very manageable or chronic conditions that are usually easily treated with compliant care and routine touch bases with your primary care physician are what a good amount of our outpatient practice is about. And what we were seeing is that there is a disproportionate shift between people of color and those that are not in terms of their health outcomes. COVID required us to say to everyone, try to stay home for a little while. And we moved to televisits, which was a little bit difficult in terms of handling and managing people who really benefited from a group setting. And the tech challenges limited our ability to have Zoom diabetes groups or Zoom weight management groups. So some of the things that I found to be difficult during the pandemic were really having patients that were very dedicated and committed to their care continue to sustain that compliant routine, simply because of small social distancing spaces in our practices and the shift to televisits and video visits that really disconnected some folks to care, but it was all for the right reasons. So we were doing, I think, a phenomenal job based on the outcomes in tracking hypertension management, diabetes management. We are a bariatric weight loss center, so we saw obesity and the metabolic weight component to be really important, and a lot of that was by having people together in shared spaces, talking about things and sharing stories, and that was compromised to a serious extent during the pandemic.
So I very much agree. I think when we think about what are the challenges in terms of healthcare and what are some of the existing health disparities and why do they exist, I think you can think about sort of two large buckets. Access to care, so how difficult is it for you to get into the healthcare system? And then when you're in the healthcare system, what is the care that you get? And we know that there are many challenges in terms of access to care. A lot of times it's difficult to access the healthcare system in general. Making an appointment can be challenging. Ensuring that you have the insurance coverage or that you have the correct insurance coverage for a specific visit, or you need a referral. There's a very complex system in the United States in terms of healthcare. And so in many cases, there can be a large barrier to entry. So it's not as easy to navigate the healthcare system as it should be. And so I think there's access to care challenges. We know that there aren't enough primary care physicians in the United States. And we also know that many of the conditions that are long-term, chronic, but very manageable conditions can be managed by primary care. So I think when we think about the access to care issue, there's a huge and existing health disparity and a gap that needs to be closed. And then when we think about within the healthcare system itself, there have been many studies over many, many years, unfortunately, which talk about the bias in the healthcare system. And the bias that our Black and Brown Americans really face when they enter the healthcare system. So the care that they get is different. There have been studies since the Institute of Medicine launched its sort of seminal paper about, it's called Unequal Care. So really health inequities within the system that are from systemic bias. There's New England Journal articles which show that, Black patients receive different care even when they present with the exact same symptoms than their white counterparts. So we know that there are existing and very serious biases within the healthcare system itself. So I think all of that preceded COVID. And we knew that our healthcare system had existing health inequities and gaps that needed to be addressed and needed to be improved upon. And then I think with the pandemic, you saw an exacerbation of the difficulty with access. So now we had to close. And just as our panel was discussing before, you weren't able to really come into the healthcare system and navigate the healthcare system in the same way that we had previously. We had to dramatically switch to telemedicine. And although there are, I think that was with and it continues to be with the absolute best intentions, because we need to protect people from existing, risks of viral transmission. Telemedicine comes with its own challenges. So we know there is an existent digital divide, that there are many people that don't have access to either the technological platform or they don't have access to the broadband or Wi-Fi to be able to have, a high enough, broadband to have a video visit. And then there's also just the virtual literacy component on its own. So accessing yet another new system to be able to get into healthcare. So I think with, we knew that prior to COVID, there were challenges within our healthcare system. I think with COVID, it really demonstrated how fragile many touch points are with our healthcare system. And I think that it's really been on large healthcare systems like New York Presbyterian to try to really look at our outreach into the community, really analyze our touch points with virtual care, make sure that we're not just putting one avenue out there, that we're understanding who is unable to access our system and what can we do differently to be able to reach them. So I think we saw an exacerbation of existence problems within the healthcare system. And I would say that access to care remains one of the largest challenges across the United States, and particularly in New York City for our most vulnerable populations.
And Adrianelli, I think you have a follow-up question, right?
Thank you so much. So following to that question, given systemic barriers, what are some of the professional challenges you've experienced, and how are you seeking to address?
So I'll just continue on with what I was saying before. So when we start to think about access to care, just as one example, and we think about the digital divide, those that have access to that technological platform or, broadband Wi-Fi, what we're really embarking upon now is understanding where are those digital gaps. What can we do as a healthcare system to either pilot programs, or we're giving devices, or we're working collaboratively with large systems like, Verizon's or, the broadband industry to be able to supply people with the necessary tools to be able to access the healthcare system in a new way. Virtual care really exponentially increased in the midst of the COVID pandemic. And I think we've learned a lot from it. So I don't think that, I don't think things will go completely back to the way they were with in-person visits, because there's a lot of use in having an easily accessible platform to see your doctor or your counselor. but it means we have to make sure that we bring everyone with us and that it doesn't widen an already existing inequity. So I think that's one. But then within the Dalio Center itself, one of our major goals is to use data to identify inequities in care. So really analyze our clinical operations, our ambulatory services, and understand, what are our patient outcomes and what do they look like when we stratify them by race, ethnicity, primary language, and where do we find gaps and how do we close them? So I think that there are existing barriers to access that we're trying to work on and trying to understand how can we as a healthcare system improve access to care. And then it's once you get into the system, how do you make sure that the care you're providing is that gold standard? And I think that there's initiatives in our center to do both of those things, and initiatives at New York Presbyterian and our university partners to do both of those things. But again, I usually think about it in those two big buckets.
I think all of that was so well said. There's really not a ton to add, but what I would say systematically in the larger context of our country is around poverty. And so a good amount of what we're talking about is rooted in the structural and socioeconomic challenges that we see in this country, and I will say it in that way. So poverty stems into education, and so education stems into your ability to comply with your medication regimen, to fully appreciate even the multiple diagnoses that you may be thrown by your primary care physician who's dutifully working through their visit to make sure they can see X number of people per day to satisfy, a per member per month kind of quota. And so when people don't have the time to explain to patients what's happening and the impacts of not taking their medication, or when a person says to me, I'm not able to refill my prescriptions, so I cut them in half to make them last longer. The efficacy of that medication is no longer viable or valid. And so we really have to understand how to care for people and meet them where they are. And that's where public hospitals, I think, have space in this country, because we're experienced, while underserved, we're experienced at dealing with populations who have been compromised. And they're only vulnerable because they haven't been well cared for in many different ways. So that manifests in so many different spaces in healthcare. So implicit bias, to what Dr. Yashar was saying. You can come in and they'll say, you're a strong Black woman, you don't need that medication. Or you're overreacting, so I'm not going to do that for you in childbirth, resulting in high rates of maternal morbidity. So what we see in healthcare and what people continue to study, but I don't think we're actioning as well, is why things are so different. And that's why I'm very impressed when there are bodies of work that, like this forum or like the center, to actually say, let's action something different to offset those barriers. Because for 50 years we've been talking about disparities, and now we need to start actioning the work to offset disparities. And a lot of that is through grassroots education and having conversations with people and appreciating where the barriers are. What's precluding you from managing your health well? What have you learned from your parents about cooking that doesn't contribute to your ability to manage your caloric intake? I mean, we have to really get down to the details of generational mores that are a part of healthcare, language divides, religious issues around blood and blood products. I mean, there are just so many things that come into why people of color are treated and handled differently. And now we just have to start talking about the action plan at the federal level in terms of what that looks like and programmatically what we can do to offset it.
I can just add to that, because I could not agree more. And I think I've made a new partner. So I think after
what happens at the panel.
After this panel, I have a feeling we'll be connecting. Because one of the things that we're very interested in looking at is that healthcare, so although New York Presbyterian, Columbia, Cornell is an extremely large healthcare system, and I truly get to work with experts in healthcare. When we think about someone's overall health, healthcare is only 20% of that. Everything else that drives someone's overall health is education, food, housing, economic stability. It's a lot of the person outside of the healthcare system. And it's so important that we understand that we understand how, policies in terms of redlining in the 60s and 70s and precluding Black Americans from the development of of housing security and wealth has long-term impact over time, because financial stability is linked with health. When we look at zoning for schools, or we think about how climate change and urban environments impact our students' ability to learn, and that has a long-term impact on overall health. It's really important that we start to bring together all of these pieces about the social determinants of health and healthcare, and then are really looking at, well, what are the systemic barriers to that? And I'll just, I was speaking with a colleague of mine and thinking about, students in urban environments in New York City, in downtown Boston, and the fact that they can correlate how hot the day is to how well people are going to do on a standardized exam, because if there's no air conditioning and people are becoming overheated or too hot, they don't do as well, and that performance tracks with students over time. So if they're able to put in air conditioning system and make sure that students have the ability to concentrate and learn, people do better. And so it's understanding all of those ties and understanding the full system that allows people to attain better overall health. There's one last study which has been talked about for many years, which I think is really important, and that is the tie of education to health. So just raising the overall education level of a community improves the overall health of the community. And that's because access to jobs is better. That's because understanding and the health literacy of the community is better. And so I think it's very hard to pull out healthcare and like the systemic barriers in the healthcare system without thinking about exactly what what Ms. Carrington was talking about before, about all of these other factors that lead to overall health. So I think it's really the time to start understanding inequities and disparities and figuring out an innovative approach to really move the needle in health and healthcare together. It's very hard to pull the two apart.
And I definitely want to come back to policy and government actions that we should be focused on. I just want to make sure, Errol, that you have an opportunity to talk a little bit about what some of the challenges you've experienced in our city's communities during COVID in your perch at Health First. So I want to make sure you can.
Sure. Yeah, I appreciate all the comments, and so I'll just sort of add on top of what was already said, because I'm aligned 100% with the feedback, specifically around access being one of the biggest issues, but the fact that just having an insurance card is only 20% of the reason why someone will be healthy. So as a health plan, we are thinking about whole person health and how can we invest in other parts of the member. And so just to give some examples, we partnered with City Harvest because one of the biggest issues that arose during COVID back in March and April was food insecurity. And we were able to pop up food pantries in food deserts where people had an inability to get food or were waiting on long lines so that they could get food. And in the instances where they weren't able to leave their home because they potentially had COVID, we were getting food delivered at least to their door. And so that's just an example of a health plan realizing that if someone is discharged from Harlem Hospital, from Presbyterian, and they go back to their home after discharge and the refrigerator is empty, they will end up back in the hospital. And so the importance of food after someone's discharge is so critical to avoiding the readmission. So that's how we step it as a health plan. On the other piece, on the digital divide is not just with the patient, it's also with the doctor. There are many community physicians, they're called FQHCs, Federally Qualified Health Centers, small doctors. These are small business owners that had closed because of the pandemic. They don't have the wherewithal or the technology or the money to fund telemedicine. So it wasn't just the fact that the member could not have a phone or did not have the minutes to talk to their doctor. It was also that the doctor didn't have the technology to talk to their member. And so we accelerated our mobile app launch and our mobile app gives access to a teledoc, which is a telemedicine vendor. And if the physician also had telemedicine services, they could also access the member through that panel as well. But then we also help these community physicians with technology so that they could start talking to their patients as well, because these were also, many of them, minority small business owners that were closed because of COVID. The last piece I'll just mention is on aligned incentives. And so there was a discussion on implicit bias. One of the ways to combat implicit bias, we believe, is through a quality incentive program. I'm happy to say that both Harlem Hospital and Presbyterian participate in the Health First Quality Program. And what it does, it actually pays more money for outcomes. And so an example is, if a woman is over 40, a doctor's rewarded if they get their mammogram. If a patient has diabetes, a doctor's rewarded if they do a foot exam. Those are aligned incentives. That avoids implicit bias, because then you don't have different treatment based on race or ethnicity, because they're getting rewarded to do it to everybody. And so it's a way to try to make sure that, Atul Gawande talks about checklist manifesto. There's a way to make sure that the same level of care is being given to everybody, and that everyone gets the same access to care. And then the last piece I just mentioned, because everyone was touching on so many important topics, was think about the Bronx. So when Cross Bronx was created, the Cross Bronx Expressway, it was done after there was a shift of people that were non-minorities leaving the Bronx. Minorities moved into the Bronx, and then they needed a pathway to get from suburbs into New York City. So they built the Cross Bronx Expressway. They literally built a highway through low-income populations that were black and brown. The outcome of that, many years later, the Bronx is one of the highest places of asthma for pediatrics, for children, because they literally live under a highway with trucks passing by. So how do we combat that? We actually work with organizations and examples like Air NYC, where they're going into homes. They are teaching parents how to use their inhaler with their child. They're also looking for mold in the house. They're also looking for a potential rats, roaches, mice, feces, all those types of things, cleaning it out. So that at bare minimum, we can't change the Cross Bronx Expressway, but what we can try to do is make sure that a low-income home is clean so that the child can breathe. And so those are just some ways that as a health plan, we just don't give an ID card, but we're thinking about whole person health.
Yeah, thank you so much. It's interesting. I think it begs the question around what are the realistic strategies, through government in particular, both at the federal and local level, that can be taken to eliminate some of these barriers and address some of these health disparities. And do all of you each have thoughts on what are those realistic strategies? And I would also ask, as a part of this with the new administration, what changes you might expect to see?
Yeah, I can start and then have folks jump in. So for us, I'm excited about what I'm seeing from the new administration in terms of the level of diversity at the cabinet level. And it's not diversity for diversity's sake. These are some of the most qualified people in the country, which is also a good example for corporate America, that you can get to diversity at the top and not sacrifice expertise, which for some reason is still a misnomer in today's society. And then the other thing is there is a focus on health disparities. People are saying systemic racism. People are saying systemic bias. There was executive orders written by President Biden on racial equity in healthcare. So that's a start. That's a good framework. Things that we could see change are, I think, examples about paying for outcomes, rewarding doctors that can partner with community-based organizations to go above and beyond around the member. So, for example, there's really no incentive today for a hospital or a physician to partner with City Harvest to make sure a person gets food. That should be part of the reimbursement, to say, if I discharge a member and they don't have heat in their house, how do I make sure they have heat in the house, or how do I make sure they have food in their refrigerator so they don't come back? That's not, it's kind of like separated today. It's very part and parcel. And I think the other piece too is also around ethnic concordance research. So ethnic concordance just means you can find a doctor that looks like you, speaks like you, comes from the same background. There's lots of research that says outcomes are better, adherence is better, talk time is longer between the physician and the patient. And we need to invest so that there is more of an opportunity for people to find doctors they want to talk to. What are the programs to remove debt so that people can go to school, become a physician, and not be saddled with debt? What are the federal government programs that will make sure that people can find doctors that look like them because they tend to speak up more and be more open and honest about their sickness? That means the doctors can actually treat them better. And then I think implicit bias also will be sort of reduced the more we talk about it. So there's a study from the Philadelphia Children's Hospital where they actually did an IET test, implicit bias test, which is a validated study by Harvard, and they found like 95% of the residents had a negative connotation towards Black patients. And it was either that they thought they weren't going to listen, or as was said previously, oh, they have tough skin, so, we can like put needles in them and they won't hurt them. And acknowledging the bias, then you can actually change it. If you can't even acknowledge it, you can't change it.
Thank you very much.
So Errol for president, but I think that one of the things I would offer on a more granular level, there are 4 or 5 things that as he was talking I was noting, and I love when there's synergy. So directly, I think we need to allow people some paid time off. Many people make bad choices because they have to go to work. They must be there because they don't have sick hours. They may not have the ability to be insured through their place of business. And so I think that's very important for us to appreciate when we talk about access. People want to feel better and they want to live healthier lives, but the choices that they're faced with near daily in many cases are the reason that they're not as compliant as possible. So I think paid time off is one. Prescription drug benefits are another, because until we are 20 years into this, the folks that are unhealthy are going to remain unhealthy for a while until they're on some kind of medication regimen, until significant lifestyle changes are adopted across all aspects of the Black and brown community. And so we really need to just look at how difficult it is, and specifically how costly it is and inaccessible for many who have chronic conditions to continue to maintain that treatment regimen. And specifically some of the new diabetics, they're just lost in their ability to really manage their disease process. I'm looking at an expansion of a program called the National Healthcare Service Corps, which actually incents by eliminating some of that significant debt that Errol was mentioning. When you go into communities of color and you specialize in primary care, inclusive of pediatrics, HIV and virology services, and GYN. So the more people that take up a program like that and are seated in communities of color for 2-3 years as their debt is being offset are really promulgating healthier communities. And that's where some of these, at the quarterback of the care, we call it primary care medical home, but when your doctor's the person who's really spearheading everything that you're doing and they appreciate the specialist you're going to, the cost of healthcare goes down. And also someone is not navigating the system by themselves. So that's one of the expansion programs that I think would benefit communities of color. And then the last is something that we as hospital executives can do on our own. We've created something at Harlem called the Medical Book of Business, because I found that I have really brilliant residents. They're coming out of school. They are a 99% board pass rate. People don't know that about us, but we do have 99% board pass rate. However, they don't know anything about the business of where they're working. They have no clue about what fuels it, what finances it, words like implicit bias, conflict resolution, appreciating denials, knowing what quality and safety is about. They come into the healthcare setting completely ill-equipped to really manage the total person that we've been talking about. And so a component of medical education or graduate medical education that requires them to understand where they're going and who they'll be seeing, I think is required in order for us to make meaningful change.
That sounds like a template everybody could benefit from.
I completely agree. As a former associate DIO who helped run graduate medical education at New York Presbyterian Hospital System, I fully agree with you about educating our future doctors. Well, future attendings around the sort of the business aspects of healthcare and understanding the payment models and the payment systems, because I think until everyone truly understands the complexities of care, and in a lot of cases until people have been in the system as a patient or a family member they know has been in the system as a patient, you don't truly understand how challenging it can be to navigate our healthcare system. But I think I actually really resonated with everything that was said, but one comment that I think is particularly meaningful because of the work that we are embarking upon in the center is really thinking about that tie between the social determinants of health and healthcare. So as Errol mentioned, understanding that if you don't have food in the home, you are more likely to use the emergency room. And I think that's where that gap is not necessarily seen at the federal level, where we're looking at comprehensive management and saying reimbursement should really be, we think about how we take care of the entire patient. So it is getting food in the home. It's thinking about mold abatement and how that we know that if you have mold in the home and you're an asthmatic, you have more frequent ER admissions. It's ensuring that we can, take part in preventing many diseases or exacerbations of diseases, and that's part of our healthcare system. It's not over there, and then healthcare is siloed in that sort of it's very stochastic. You're either in the healthcare system or you're not. And I think it needs to be thought of more of as a continuum, where you're always part of the healthcare system. You always have a touch point, a tie through your primary care doctor or, in whoever you're seeing, but you're only part of a system who is looking at your overall health rather than just an exacerbation of it when you need to see the physician. So I really, it's part of what I think is so amazing about what I think we can do in the United States to improve healthcare for everyone is to start to be more, I think, more critical about those relationships and the ties between your social environment, your family environment, your home environment, your ability to go to school, and really understanding those ties and how the local and city and state government can help support better overall health for its constituents.
It's a why we believe very strongly in advocating for policies and change that will improve New Yorkers' lives. And I'm listening to all of you talk about the things that need to be done and the relationships that need to be strengthened and the policies that need to be strengthened. Would you have advice for us on a tactic or a strategy that we should focus our advocacy efforts on that you think would be compelling and helpful?
Oh, sorry.
Go ahead.
Well, I was just going to, for us, it's really driven by some of the work that we're doing. So I think that it's quite important to understand what's most important to those that you're serving, and then use that as a platform for advocacy. Because some of the work that we are really looking to pursue is around women's and children's health. With a focus on maternal mortality, with looking at, early childhood development. And so, when we start to think about what are some of the platforms that we want to take in terms of advocacy, they most likely will be within, women and children, just because that fits within some of the work that we're doing. And there's actually a lot of good work within New York City and state right now as it relates to maternal mortality. So the New York State Birth Equity Improvement Project is kicking off, where one of the members are thinking about what does birth equity look like in New York City and New York State, and how can we as a healthcare system improve. And I think tying all of our advocacy work to the data that we have. So looking at where are there existing gaps in care, how do we think they need to be closed, and then how do we use that as a platform to advocate on? Because there's so many things that you could choose, I think, is the problem. I was, as I mentioned, I've been speaking with my colleague who's a physician in Boston, and they were advocating for, for insurance reimbursement for mold abatement and for air filtration systems, as well as for air conditioners. And that was tied to decreasing asthma exacerbations. And so I think and that was very successful. So, as we start to think about some of the things that we want to advocate for, I think it really depends on, what problem you're trying to solve and what's the constituency you're trying to report to.
Yeah, I can brag on YMCA a little bit, but the work that has been done on childhood obesity reduction is absolutely amazing. The fact that you have a sliding scale for your gyms so that people that cannot afford a Y membership can still get access. After school programs, SAT prep, that's free of charge. I mean, I think you guys are doing all the right things. The diabetes prevention program that now gets reimbursed by Medicaid and Medicare, awesome. So there's so many, I think, programs you guys are doing. YMCA, like many nonprofits, suffer from being the best kept secret in New York City. So it's just getting the word out at the power that you guys have. I mean, the new immigration centers, which are now allowing immigrant populations to enter into New York with a hand, so that they can navigate and find out all the different programs they're eligible for. I know some of your locations are now being used for COVID vaccinations. That tears down barriers for people who are scared and nervous. That decreases vaccine hesitancy. Like, I don't know anyone that I live in the Bronx. I don't know anyone in the Bronx that wants to go to Jacob Javits Center, but if they could go to the Y in Flatbush, yeah, I'll get vaccinated there because I've been there before. So I think you're doing all the right things. I think it's how do you catalog it all and showcase that you're not just a gym, like you literally are a healthcare behemoth with all the different programs you have.
Well, thank you for that wonderful.
So I didn't know any of that. So I think what the Y can do is share with the world more the outcome metrics and how targeted and focused these programs are to offsetting some of the numbers and the narratives that made you invite us on the call today. So I think if people knew that there, in fact, was a targeted approach to communities of color like this symposium, they would understand that there's an appetite at the Y to do more, to partner more, and your programs, as I'm just listening, are just so right on and so relevant to what's necessary. But I would say maybe there's an access issue there also because, I'm a member, but many of those things I didn't even know. And so I would say there's a lack of awareness about really how synergistic the relationships are and how some of the things that your doctor's telling you map you to the Y. And that is helpful also just in terms of movement, exercise, maybe exposure to non-traditional contemplative practice like yoga, or meditation. These are not things that people would immediately practice on their own, but with exposure and with kind of groupthink from folks that they trust, credible messengers I always call, then that's the best way for us to kind of partner in really this journey. But that's amazing. I just think that all that you are doing is so spot on, and you really are partners in health, frankly.
Yes, well, we're going to be partners with all of you. We are, and we'll continue to strengthen those because there's certainly room for improvement, and there's so much more we can do. And like I said, we created Prevent Health way back when, 150 years ago, and we need to really lean into that. I do just want to return to something that Errol mentioned about vaccinations and ask all of you around vaccination hesitancy and the fact that the number of Black and brown people receiving the vaccine is significantly lower compared to white people, and what can be done to address this. And I know there are many people on the call that might want assurances that you can give to them about the safety of the vaccination. So if you could address that, that would be great.
I'm happy to. I probably 2 to 3 hours a day talking about vaccine confidence and how we can build that in our communities. And I think there are a multitude of reasons why people are hesitant to be vaccinated. Particularly in Black and brown communities, there is a history of well-established distrust, which has been, for centuries. This is because of the abuse of Black and brown bodies in the United States. It's distrust in the government because of government-sponsored studies. And it's well known, there's a recent survey that looked at if you are aware of the Tuskegee syphilis study, you were less likely to want to be vaccinated. So I think that starting with a recognition of the history in the United States is incredibly important, and not saying that we discount that we discount people's feelings and beliefs and hesitancies, because they are valid. And I think that validating people's feelings is the first and most important thing that we can do as a healthcare community. And then I think it's really partnering with people to give them the information that they need to feel comfortable. So I've given a number of vaccine talks. I think I'm probably upwards in the 30 to high 30 range at this point. And I learn something new at every talk. But the first thing that I say is that I'm not here to coerce anyone into being vaccinated. I'm here to work with you and to support you into making a decision. And that may mean that this is the first of many conversations that we need to have. It may mean that you were already nearly there and just needed one more fact to get there. Or it may mean that, you are really still in that watching and waiting category and just don't feel comfortable yet. And all of that should be expected, and is, I think, meeting people, and I actually think, Ms. Carrington, you said this earlier, meeting people where they are is first and foremost, we have to. So first, acknowledging the history, acknowledging people's feelings, acknowledging the beliefs, acknowledging all of that is the beginning. And part of this is rebuilding trust in the system. So it's not just this one time to be vaccinated. It's saying, what are we going to do long term to really mitigate the health disparities that got us to where we are right now, where we have to look at data that shows that Black Americans have lost 2 to 3 years of life expectancy. Hispanic Americans have lost 3 years of life expectancy due to the COVID pandemic. Those are just terrifying numbers. And so we have to recognize, we have to rebuild trust into the system, and we have to think about the long term, what are we going to do as a healthcare community to improve access to care, improve outcomes. So I think it's a beginning conversation. And then it's really just the facts around the current vaccines. So Moderna and Pfizer are the two vaccines that are available in the United States, and they have truly, phenomenal efficacy profiles. In study, they were 94% effective at preventing symptomatic COVID disease, and have now been looked at we are really able to look at Israel and see how the vaccines are performing in real time, because they have vaccinated an overwhelming majority much more quickly than we've been able to achieve in other countries. And so we've seen both in study and then in real life that these vaccines work very well. We've also seen in study and in real life that these vaccines are incredibly safe. And we've now vaccinated over, I think it's 50 million people, and adverse effects are very, very rare. And the side effects that people, I think, get very worried about are minimal and resolve within 48 hours. So we know that these vaccines are very safe. We also know that these vaccines work very well. And I think when you put those two together, it's really asking people, where are you today? What are your concerns, and how can I help answer those facts for you? How can I give you more information to make you feel comfortable so that you were where I was, where I sat down and was so overjoyed to be vaccinated, I started crying. I was so excited, and I was vaccinated, I think, 10 days after the first doses were brought to New York City. So I think that, if I can, I have two talks tomorrow around vaccine confidence and talking about the specifics of the vaccine. And we're launching a couple of new videos on our website that really break down for people the facts of the vaccine. And I think one other thing that I think is really important for people to understand around these vaccines is that, yes, we were able to get them in 1 year. And I think that is actually a triumph of science. And it's a triumph of being able to say, when we are all laser focused on getting one thing done, because we know it will save lives, look what we can do. But getting the vaccine in 1 year does not mean that any of the safety standards were skipped. Every single safety standard was still met. All they did was overlap timelines. So, when we look at a traditional timeline for a vaccine, it takes a little bit longer. But there's also a lot of red tape. There's the first parts of the studies, then you pause, and there's the second part. And so when everyone is focused on just doing one thing and doing it really well, you can move mountains. And so I want people to, if the one thing they can walk away from it is that Moderna and Pfizer's vaccines had good diversity in their clinical trials. They were well representative of our population across the United States. And both vaccines are very safe and work very well. And I think that's really the tagline. I think we're going to see more and more vaccines becoming available in the United States. And so sometimes I'm asked, well, what's the best one? What's the best vaccine for me to get? And I tell people the best vaccine is the one that's available to you. Because as we all become vaccinated, everyone benefits from that. So it's not the subtle differences between them that really matters too much. So I think, long comment short, the vaccines are safe. They work very well. They've been studied a ton of eyes and hands and hearts have been focused on these vaccines to make sure that they are safe. And so I think there's a ton of information out there, but make sure to get it from reputable sources. So cdc.gov. Go there for questions and frequently asked questions, and if you have concerns, because that's data that we know is verified and true.
That's so helpful.
I'd just add to that, so from our lens as a health plan, 1.6 million members, 1.2 million of them are Medicaid eligible, so they make $15 an hour. The vast majority are immigrants, low income. We have to say everything that we just said slightly different so we can reach them. And so I commend New York State for having the Vaccine Equity Task Force. It's one of the co-chairs, one of the 4 co-chairs is my boss, Pat Wong, CEO of Health First. And what they've done really is give the information to these communities and organizations so that they could then have it conveyed to their communities from a reputable way that's culturally competent. And I think that's extremely important. Another piece I think which is awesome, Torian Easterling is the new health chief equity officer for the Department of Health. And some of the surveys she uncovered was the hesitancy specifically around African American and Black populations is the speed, which was talked about, the speed of which it came, the side effects and trust of government. And I do think we have to acknowledge trust of government because we just came through Black Lives Matter protests and police is part of government. And so saying, well, I don't know why they don't trust it. It's like we go through Flint, Michigan with water. We go through what's happening in Texas with electricity, police shootings, and so many different things, the juxtaposition of Black Lives Matter and the January 6th protests. These all have to be, January 6th insurrection, these all have to be considered because when people say a lack of trust of government, it's because they felt it themselves individually. They felt being stopped and frisked. They felt a loved one being put in jail. They felt whatever they felt, being evicted. And then now they're saying the same people that did all these things to either me or my family now want to give me a shot. No thanks. So I think you have to truly acknowledge that trust is there. And that's why a trusted party explaining the vaccine is so important. So when they see a person of color get a shot and say, I got the shot, I had a little chills for a couple of days, I'm okay, and I feel really good, that will then start to reduce the hesitancy, just specifically for my own mother, who's over 65. It was a 3-month conversation, and she's saying, I heard, because she's speaking to people on WhatsApp, and I'm like, I know you heard, I don't know who you heard from, but let me tell you what I know, and I'm reading all these studies. And just, if someone sends you an article about potentially in Seattle there was potentially a death from a vaccine, and just the explanation for someone to feel confident to ask that question, and then to say 1 out of 50,000. So, how 5 million were done, 1 out of 50 million, 5 million were done in New York State. And you have to have those conversations in an open forum where people can speak to their hesitancy, speak to their fears, so that you can sort of erode them and reduce them. The last thing I'll mention is the websites. So we have a dedicated call center that's actively booking appointments on behalf of our members, because the websites are extremely hard to get through. Many of them are English only. By the time you get to a spot that the vaccine is already taken, I volunteered at both Yankee Stadium and East Gun Hill Road many days. The neighborhoods that these vaccine pop-up locations are in don't necessarily match the people online. And so you have folks that have the ability to be home, working from home, and refreshing their laptop every 2 seconds, finding a website, while essential workers that are in the field working can't have the luxury to look for an appointment. So I think part of health equity is also how are we going to help the folks that need the most get their vaccine. We literally took the way we book an airline flight and said, oh yeah, use it for a vaccine, when we know who books airline flights and we know who doesn't. So health equity and systemic bias played into a part of how we're booking vaccines. And that's where we have to take a step back and say, who do we want to get vaccinated first and why? 65 plus communities of color that are most vulnerable. How would they book their vaccine? Let's start there, because they're most people that are impacted, and work backwards.
Thank you so much.
So I do 2 or 3 of these a day also, so that was a checklist. So Dr. Yasha did the whole checklist, right? But what I would offer is that the only 2 things that we share in our talks, and we do them with children, we do them with adults, because children are very impactful. And what we've learned is specifically in households where English is not the first language, the children are really the translators. The children are the messengers who are translating from television or certain websites back to their families, specifically their grandparents, who are the ones that we want vaccinated. So we've taken kind of a multimodal approach on social media to talk to different communities of color, different populations, and to directly partner by, frankly, sequestering some of our appointments and saying they need to be for people of color. They need to be for people who have medical record numbers that are attached to our hospital. They need to be for people who were disproportionately dying during the first wave. And we need to ensure that external herd immunity, specifically in my hospital. And so my primary catchment, if you looked at the heat map, it was bright red. And so making available to everyone in that heat map vaccines so that we could actually return to some normalcy is what's strategic and what's required. So we've done that, by making sure that we manually make appointments for people who have medical record numbers here. And that's what we've had to do to not circumvent the system, but try to find innovative ways to create access and to make inroads for populations that are willing and that are not hesitant, but that are simply unable to access vaccine. And we've seen them come in mass at Harlem, and I can actually begin to track and monitor the fact that we've had no side effects. No adverse effects. So no one has died from being vaccinated or from the impacts of vaccination. There's no live virus in the vaccine, which is really important. And given the fact that a flu shot does have live virus, given the fact that we have talked about Tuskegee, it's important to know that you're not being injected with COVID by getting this vaccine. And the building blocks of the technology are so old that people should want to rest on them. They're 20, 30 years old. So what I really want to make sure people appreciate is the timetable of this particular vaccine is because we had to populate it with the genomic sequence that was just available a year ago. But everything else around it is credible. Everything else around it is solid. It's evidence-based. It's something that you may have experienced yourself and taken willingly, but you just didn't know how long it took to put on the market. So I would just offer that the timetable is something we really have to talk about very often and to break down the components of the vaccine, specifically to the mRNA piece. And the last is just to appreciate that everyone doesn't talk DNA and mRNA, and so people commingle them all the time. So there is a perception that this is modifying your genomic sequence, or that it's going to modify your genetic makeup, and that's just not true. And while people like to laugh it off as an urban legend, when you keep hearing mRNA, the mind easily kind of translates that into my DNA, and people are very protective of their DNA. So I would say that that's what's important for us, and then to appreciate that we need to talk about what the underlying conditions were before that got us here. So you don't know the impact of the vaccine. I can say yes, you don't. But you also don't know the impact of COVID. I've seen people with, COVID brain, COVID lung, people who were not asthmatic before that have to use rescue inhalers. So we're still seeing what COVID mild and what COVID severe has done to people as we study this. So I just want to make sure that we're comparing apples to apples, in that you don't know what post-COVID looks like, just like you don't know what post-vaccine looks like, but why take the chance? And that's where the calculated risk of being informed versus really leaning into your fear more than into what you're being told by people who you trust is important. So we've gotten pastors to come. We've set up a campaign so that people of color that are trustworthy are able to actually show people, I got it, and I got it at Harlem. And if you get it at Harlem, it's okay too. That there's no different vaccine at the different sites, that we all get the same manufacturer's lot, that what's at the armory is also what's here. So it's really just important to listen to people, and a lot of times it's about having a one-on-one or a smaller conversation, because people will not disclose the things that they're feeling so openly. And it's important for sometimes you just to say, I'll walk you downstairs if you want to. You can be my, lot buddy. So a few people, 8 other people got vaccinated with me. They're my lot buddies. We see each other in the hallway. We're high-fiving, because we've now shared an experience. So we've just tried to throw everything we can at this, because it's very critical that people be vaccinated, specifically healthcare workers, and that's what we're struggling with a little bit.
Well, thank you for all of yep.
Sorry, I just wanted to, because I love the, there's so many similarities in the language that we choose and used to talk about vaccination. And I think that everyone has spoken about the importance of access, and that if there's not equitable access to vaccination, that further erodes trust. So ensuring that, we can message all we want about building confidence in terms in, building confidence in vaccination, but if people then can't access the system, then we are back at square one. And so, we've done a lot of very similar things up at the Armory, where we closed to New York City residents only, and then we reserved 60% of all of our appointments to patients that are from the surrounding areas, so South Bronx, Inwood, Washington Heights, and Harlem. And I think that's incredibly important, because we looked at exactly the same thing. We looked at those heat maps. Where are we seeing the most effects of COVID-19 disease? Where do we look at these heat maps and we see where our patients are coming from, where our patients are dying? And it's incredibly important that we are reaching out to those communities to make sure that we can vaccinate them. So we have a huge number of people that are just calling our patients day in, day out to make appointments for them, and really kind of subverting some of the concerns about the digital divide and virtual literacy by just calling patients and making appointments, working with our community-based organizations to refer their patients into our system to make sure that we really are targeting communities that have been disproportionately affected by COVID. And one other, I absolutely love that it's so important that we talk about how the vaccine timeline was slightly compressed, but not skipped. And I think that's an incredible nuance that people need to understand, because the technology is old. And I think about it, and it's exactly the same thing, that it's like a message in a bottle. So you're delivering that vaccine as a message in a bottle. We already knew how to make the bottle. We already knew how to construct the message. All we needed to know was what to write. And so once we got what's the code that we need to put on that message, we could create it very quickly. And so I think people don't understand that the message part of it was the end of 20, 30 years of development of mRNA technology to be able to get there. So I've started to just say that it's like a message in a bottle, and we had the bottle waiting. We knew how to write a message. We just needed to know what words to use. And that's really where we got the vaccines that we have today. But I think it still gets back to that same thing about access to the healthcare system and ensuring that we are really customizing the tools that people need to be able to gain entry into our healthcare system.
Well, thank you for those incredible insights around education, communication, so helpful. And I want to turn to Adrianelli to, I think, ask what will be the final question. There are so many more things that I know we could cover, but I also want to be respectful of your time, but I want to make sure that she has the opportunity to ask one of her important questions. So Adrianelli, back to you.
Yeah, I've done so much for like racial inequalities in healthcare and how much goes into it. And I know that one of the important parts also has been. So I also want to ask a question to the panelists, Ms. Carrington. What impact do you think COVID is having and or will have regarding the mental health of Black and Brown teens?
So I have to just say, that's such a good question. On Sunday, I participate in a group. One of them is the other co-chair on the Vaccine Equity Task Force, Jennifer Jones-Austin. 13 of us are actually doing something called Sunday Supper every week, where we are targeting teenagers, where we are targeting people who may have been in the home for some time without interpersonal contact, without the ability to get mentors. And so what I will say to you is we are so aware of the impacts and how devastating this pandemic has been on young adults that we're already trying to work through a solution. So I think it's important to understand anxiety, feelings of sadness, questioning oneself. Those are all natural components of post-traumatic stress. And I think the whole country has gone through such a traumatic experience that we need to all be therapized in a way to figure out what we need to do to return to normalcy, not go to work, but normal headspace. How do you forget all, 500,000 people who have died? How do you forget missing your prom? How do you forget not having seen your friends or having been in the home for many, many months because your parents are very, very fearful of contracting COVID? So I know some people have said they've been relegated to their home for the entire year, just going only to the grocery store because they've really complied with what's been said. So I think the headspace for everyone in this country is slightly altered, and we need to just be okay not being okay. It's okay to say I'm frustrated. It's okay to say I'm overwhelmed. I'm tired. I don't feel well today. I want to talk to someone. And when you don't feel well for an extended period of time, it's okay to seek help. So I want to just talk about destigmatizing mental health for a moment. Every person across all of these economic stratas that we've talked about, rich white people, poor brown people, poor black people, they can all have equal opportunity to have mental illness. Stress and anxiety really impact people in very meaningful ways. And so I just want everybody to understand, if you're feeling any kind of way, that's actually normal. If you felt no impact over the last 2 years, then that's when I will say that there's something that's a little bit off. So just know it's okay. Know you should talk to people about it. Understand that in Black and brown communities, mental health and going to a therapist is not always going to be the first thing that's offered to you. In fact, some people who might be older, if you're in an intergenerational home, may question why you want to talk to someone, or may call the mental health professionals by, unorthodox names. But push past that and maintain your own wellness. Keep your safe space and ensure that you have a support team around you, and really a self-care regimen is required. You have to outlet. You have to exercise. You've got to get out safely, and you've got to make sure that you're talking to people and that you're stimulated in some other way besides just watching this screen, which we've all been watching. These screens we've been watching for 2 years. That's not regular either. So we just have to make sure that we continue to talk about it, get help if you need it, and also realize that there are so many people around that are willing to help and provide support.
Thank you so much. Well, I just want to thank you all for your tremendous insights. I have learned so much, and I will say this has certainly confirmed the need for us to engage in these important conversations and to keep doing so, and to make sure that all of the questions are being asked, and to make sure we continue to demonstrate the need for change and what are those policies, practices, and actions that can lead us there. So I'm very, 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 very grateful. So I know we can't applaud, but I just want to say thank you to the great panelists and to my great co-moderator. And I do want to take a moment to thank today's organizers, LaToya Jackson and Catherine Colglazer, for their incredible efforts in making today possible. And I also want to thank the WISE EDI, or Equity, Diversity, and Inclusion Task Force chairs, Doherty Jourdain, Liz Toledo, and Jim Trocchio, and all the task force members for putting so much thought and care into today's event. And thanks everybody who's here for supporting our essential work, for being open to learning and understanding what role you can play to affect change. We appreciate you. We need your support. Stay with the why. Continue to work on all of these items. And I want to make sure everybody knows that, again, I mentioned this is the first of 4 discussions. Our next one will be April 28th, addressing racial inequities in education. I think given today's robust conversation, I do not think this will be the last conversation we have, especially because we are living through a health crisis and there's still so much work to do. So really, thank you again to the panelists. We do have a video that I will share from the Lieutenant Governor Kathy Hochul, who had wanted to participate. I think we'll roll that now. Interesting that I think her comments align with much of what we talked today. So I will give our tech aficionados an opportunity to share that video. So once again, I just want to say thank you to everybody who's here and to, again, our fabulous panelists for, I think, at the end of the day, really demonstrating, again, the importance of education, communication, and partnership. We look forward to continued conversations, and I'm just saying, I don't want it to end. I don't want to hang up. I really appreciate you all being here. And if there was anything that you wanted to say in closing, I'm certainly happy to give you that opportunity. If there's anything that you're waiting, dying to say that we didn't get to.
I just add, Sharon, that this is not activities out of charity. This is really about people, the health of our country. And, injustice anywhere is a threat to injustice everywhere. So there's savings, there's better health outcomes for the planet, there's less burnout for providers if we can get health disparities equal footing regardless of race. So I just don't want this to be like, it's a nice thing to do. There's actually true economic impact and longer life out of some of these activities.
Yes, very well said.
I would just, I think my final comment will be that being able to share the stage with people like Mr. Pierre and Ms. Carrington continue to give me hope in what we can do in this country and what we can really do to change healthcare and make sure that we are able to provide care to our most vulnerable. I think that although I've been quite saddened by the recent data around, life expectancy in the United States, I think we have to say this is a challenge where we should be doing better and we can do better. And we need to be able to reverse those numbers and really give people the life in the U.S. that they deserve. So it's been a pleasure to be here this evening, and it's a pleasure to share the stage with two people whose work I truly you give me hope to make sure that we can all do this together. So thank you.
Thank you, Dr. Yashara, and thank you, Errol. I really have been very blessed by this discussion. What I would just offer is that the pursuit of happiness is the pursuit of healthiness. And you really, really have to appreciate your self-care. People right now are making significant sacrifices. They're home with their children. They might have had to quit their jobs. People have died. Estate planning is all over the place. I mean, I can just go on and on about what people are feeling right now. And it's important to remain hopeful. It's important to have your own true north. So maybe ask yourself the question that Sharon asked us at the beginning of the meeting every day, like, what's my true north today? Why am I pushing? Why am I just overcoming? And it's because your life is worth it. It's because your health is worth it, and it's because our community health is worth it. So I would just say keep pushing, don't give up, and really rest on resilience. So that's what I offer.
Thank you so much. What a great note to end on, a sense of optimism. And I will just once again express my gratitude and thank you all for being here. Okay. Take good care.